So first of all, I am so excited to talk to you about this particular project. I've been following Penn Med for a long time, and I think what you guys did with COBALT and at the time at which you did it fascinates the heck out of me. I'm obsessed. So I'm so glad to have you here today. Thank you so much for coming.
Oh,
Go ahead.
Thank you. My name is Gronczewski. I'm the Chief Medical Officer of Penn Medicine, Princeton Health, and I'm also excited to be here. And we've been doing a lot of work on physician burnout. I'm a practicing emergency physician, and I've heard about burnout my whole career before I went into the field. And I heard that emergency medicine is a burnout field, and I never really understood what that meant. I thought it was just ER physicians felt like they weren't making enough money or putting in too many hours, and we've learned so much more. Thank you. I'm happy to be here.
So for those of us who don't know, not me because I'm obsessed, but for those who don't know, could you explain to our audience a little bit about COBALT and the project you guys were involved in?
Well, our project is to address workplace wellness, physician burnout, and resiliency among our staff. Penn COBALT was a part of that project and something we tapped into. So I'll speak about Penn COBALT. So COBALT is a digital platform to support mental well-being. It came out of the Penn Center of Innovation, David Ash, promoted by a dean, Lisa Bellini, and it is really a digital platform designed for real-time mental health support for practitioners, for other staff, to get them connected with a need based on a triage assessment of their individual needs. That could be from a podcast or wellness apps to group support to individual one-on-one psychotherapy. It's been very successful. It was a collaboration with United Health. It's deployed throughout the system of 40,000 employees. Princeton Health is where I'm from, is 3,000 employees, an additional 1,400 members of the medical staff. We've had about 10% of our workforce utilize Penn COBALT.
That's amazing. So could you tell us a little bit about the method you guys used for this project and why you chose it?
Well, for us at Princeton Health, it was easy to tap into. We had started around second half of 2019, our medical executive committee, medical staff leaders, we were talking a lot about physician burnout. It was coming up in our monthly leadership meetings, and we organized our efforts around that. We designed a project. We started with the physician-led task force on physician burnout. And I think from the start there, one thing that went well was we didn't tap into just the physicians who were concerned and caring about this, but nursing leaders, administrative leaders. So we really tapped into support. We started with trying to understand the issues. And from that, we really wanted to do a couple things. One, we wanted to better understand how physician burnout or moral injury was impacting our workforce, our medical staff. So we wanted to figure out how to measure it. Like, we've been hearing about it. We've been hearing people tell their stories, their own individual experiences, what they've been hearing other institutions have been doing to favorably impact efforts against it. But we didn't really know the scope of that problem at Princeton. So we wanted to measure that. And secondly, we really were careful not to try to reinvent the wheel. And a part of that was to tap into our system, a larger system. And that's really where it led us to some of the efforts that were system-wide that we could tap into.
That makes sense. So you guys took on, this was a huge undertaking, and you did it during the pandemic, which is amazing to me. How were you able to prioritize your efforts in such a trying time for all of us?
So I think we had, the unique experience for us is that there was, I think, a fortuitous intersection between our project and efforts surrounding physician wellness and burnout. So we really established a project around it in late 2019. We also identified a department, our labor and delivery unit, that seemed to have higher levels or reports of issues related to physician burnout. So from medical staff leadership, medical executive standpoint, we began tackling burnout in those two areas. So we created a project task force. We created a scope of work and timeline, and that was end of 2019. And then here comes 2020, and COVID's around the corner. And we knew physician burnout was a serious issue before the COVID pandemic. The pandemic absolutely amplified all those issues and then some. And so that intersection really gave us the platform to really energize and accelerate some of our efforts. It really changed our priorities in many ways. Some of the things in addition to, how we prioritize that, as part of our agenda and our COVID medical staff huddles, we always had on the agenda workplace wellness. So, and during the COVID pandemic, the peak of that, we had some really unique issues. I mean, there was obviously distress and anxiety, fear of the virus, of getting sick, protocols constantly changing. It was uniquely challenging times. So we wanted to, make sure that everyone had awareness of all the resources and tools out there. We also, it was clear to us that some of the suffering that was occurring from the stress of the pandemic and the workload and what was going on at home, it was important for us to get more boots on the ground support for the staff. So one thing we did was we retained a psychologist who rounded with our chaplain services. So we had huddles on frontline rounds daily. And one thing we morphed our huddles into was just not operational huddles, protocol-driven huddles, but it was always about how are you feeling, what's going on. And for example, in the emergency department was a critical frontline area for us in managing the early pandemic. We had an ER physician who got very sick. He contracted the virus, ended up in ICU, was on a ventilator, was placed on an imminent death condition, and was on a ventilator 90 days. Thankfully, he survived out of the hospital. Love him dearly, and glad he's recovered from that. But I'll tell you, when that was occurring, when a colleague is going through that, and we're already afraid and fearful of the virus, that's impacting. That kind of feeling comes into the workforce every day. So one thing we did was we huddled daily. We brought a chaplain to our huddle, and we were very vulnerable about how we're feeling. So to me, I think what changed and how we prioritized wellness during the pandemic is we were very open about discussing it. And I think also it was the first time in my career that our staff felt comfortable about openly discussing how they feel. And I don't know if it's destigmatizing the issue, but people were feeling the obvious need to discuss that. And that really leveraged not only real-time efforts, but also allowed us the opportunity for our staff support services to pull people on the side, ask how they're feeling, set up group sessions, make sure they are aware of all the resource and tools provided.
So you spoke about the challenges you guys had, and I know you had some really specific goals. So in your opinion, what do you think went really right with this?
I think efforts to communicate that, I think to allow our staff and the courage to speak up with how they're feeling, and us from an administration standpoint to have the courage to listen, and all of us together to try our best to do something about it. And I don't want to represent that we've figured out how to cure physician burnout, but we're in a much better place in combating it and having a systematic approach to ensuring our efforts are productive. But I think for us it was deeply communicating with our staff and engaging with them, and really understanding, like just doing something about it that was very tactical in nature. For example, and not stopping. So I mentioned labor and delivery was a unit that was I think under some distress during the pandemic. One of the things that come up there, the call rooms were under construction, and construction completely suspended. So now we have some obstetricians who have to be up all night delivering babies and midwives, and they don't have a call room to sleep in, right? And so that was very distressing. And it's very tempting to take on the approach, well, there's not much we can do about it. Construction is suspended, but once it's resumed, we can get around to it. We followed through. So we had a visitor lounge that was now empty because we were allowing visitation. So what if we converted that lounge into not a call room, but a break room? So we can put computer stations there. We put lounges there. We can pull curtains. So it's not a call room, but it's maybe the next best thing as a temporary fix. Also identifies alternative areas where they could sleep. And then also assure them that we prioritize our construction schedule. So absolutely day one, when the governor allows us to resume construction, we have moved that to the top of the list. But then also not finishing there. So when we finally constructed, as we were constructing the 6 call rooms for our 10-bed mother-baby delivery unit, and understand that we deliver about 6 babies a day, and then hearing about, well, our 6 call rooms enough? What about when our midwife covers? We had identifying we have a system where we have multiple private practices, and we are asking if we can have a number of call rooms that frankly outnumbered the number of babies we're delivering. So having those conversations with our practices, and again, it's bi-directional, like how are we all a part of what's impacting how we feel about the work environment? And for that, as an example, is that practice model that each practice independently represents to the organization, is that sustainable? Is that contributing to some of the burnout? So we have multiple practitioners from multiple groups coming in, having to be on call, staying up, delivering babies. And is there some different model? So we made so based on those conversations, we explored and eventually implemented a laborist model. I'm not saying that's the right fit for every organization, but for us, that was a solution to work with the providers, better understand their work demands, what their issues were, what's contributing to burnout. And for obstetricians, it's oftentimes the schedule, managing home life, your private practice, running into the hospital, and it's an intense job. So laborist model was a solution for us to now 2 obstetricians on shift can manage those 6 deliveries plus additional, and then the individual practitioners from different groups don't necessarily need to be in the hospital up all night, every night. So it was just incremental, really having those conversations to understand what the issues are being represented, but also to better understand them and communicate with the practitioners, and then really execute and do something about it together.
Wow. Okay, so here's a good one. What did you learn that you think other organizations could greatly benefit from? Because hopefully we'll see this modeling everywhere. My hope.
Yeah, I think one, it's this issue is here to stay. It's not going away. The workforce is incredibly valued to healthcare. There's a staffing crisis out there. This is going to penetrate administrative decisions going forward. It's not going away. And I think one of the things we learned early on when we were promoting awareness for physician burnout and addressing physician wellness and resiliency, and we were bringing other stakeholders at the table, administration, nursing staff, HR, et cetera. There's a sensitivity around that, which we learned this is not just a physician. There's some unique features to physician burnout, but physicians don't corner the market on burnout. This is a healthcare-wide industry. So you need to partner and accept that this is it's a broader issue. So, I mean, that's something where we pivoted. We did pivot from working on physician burnout and really broadening it to the workplace environment. And that shift really, I think, got everyone to embrace and get more on board with the initiative.
That brings up an interesting question for me. For the administration, what kind of change did you see there? Did you Was it a huge difference? Because that's where we usually see the pushback.
We had significant administrative changes during that time. Several months after the COVID pandemic, it made an impact to addressing this. One thing I think leadership is very important in combating this and accepting this and prioritizing it.
Okay, I think we're going to go to some questions, but I wanted to hit you with one more question. Let's see. If you're thinking about long-term, where we want all of these studies to go, where do you see it going? Like, do you see every institution looking at this as a framework, or what's your hope?
That's a really good question. I think, back to our one of our early assumptions with our project was to not reinvent the wheel. I think we need to continue to explore the data and evidence to quantify the levels of burnout and the impact where it is. For us, it was in that department of OBGYN. Other aspects was there was a disparity. Our female physicians had higher distress scores. Our middle-aged career physicians. So I think going forward, we need data and evidence to help quantify the scope and levels of the problem. And I think we need to ground our interventions on things that work, evidence-based work. We also have to accept that there's not just one tool or resource that will solve this, and nothing will solve it quickly. This is an ongoing, sustainable effort that will extend past all our careers, and accept that it's just not one thing. A hot yoga class is not going to solve this. A meal on the table is not going to solve it. These will all help, but we need ongoing, comprehensive, collaborative support, and we need to be better listeners of what the issues are. Again, the courage to listen and the courage to allow our staff to speak up and do something about it.
That's amazing. So the data that you guys were able to extract from this study, it's a lot of it. Is it widely available?
There's a lot of data, on physician burnout and workplace burnout. So our data that we collected, the tool we used a well-being index that was developed by the Mayo Clinic. It's a validated tool. It's a 9-question tool. Our data is not published. It's kept internally. But what is available, and one of the reasons why what is helpful in measuring is the benchmarking. Mm-hmm. So the benchmarking of all participants across the country that have used this, broken down by specialty and other demographic features, that is available as part of the survey data.
Oh, okay. Thank you. Give Dr. Craig a round of applause, everybody.